Thanks for showing up. We're at Springville today. Thank you, Chief Harvey and Springville, for sponsoring us and hosting us. And remember, the Fire College also sponsors us. We're doing one class on the road per month away from Center Point. We're here today in Springville. We got lectures 9 to 11. If you're in the area and want to show up at 1 o'clock, we're doing a skills lab. No need to pre-register to come up. We got survival flight flying out to help with airway skills. Dr. During is coming out, and we're going to do some pediatric resuscitation. And then we have an airway station and a few mega code scenarios we're going to run with me as well. So it should be a good afternoon. And I've already forgot how to work your clicker. There we go. So for those who have not participated in EMS Challenge before, this was started back in 2014-15 to get more physicians involved in pre-hospital care. Currently we're doing 2 classes a month, the second and fourth Wednesday of each month. We also have different physicians showing up next week or next time at Centerpoint. I've got Dr. Rose and Dr. Tether Payne, ER residency UAB speaking. And again, the goal is to get more physicians involved to help with pre-hospital care. You know, 30 years ago when I started out as an EMT, it seemed like there were docs involved doing a lot of things. There was a doc that checked you off on your ACLS and your trauma classes, and they harassed you in the field and in the hospital. That seems to have kind of gone away, and I'm trying to bring some of that back. Not the harassment, but the doctor involvement. Thank you for smiling. Good. Tough crowd. I'll have inappropriate jokes in a minute. For your certificate, it'd be in the chat box how to get that. You can also email Alabama EMS Challenge today if you want Con Ed credit for that. We have both nursing and paramedic Con Ed credit. So thanks to the ENA for sponsoring us. Updates, the STEMI systems currently is only in the BRIMS region. That plans to go statewide, hopefully within the next year. They're going to kind of merge it with the CARES, which is the Cardiac Arrest Registry for Enhanced Survival. That's what we're putting in our data, what happens in the pre-hospital area with our out-of-hospital cardiac arrest. And then we add data from the hospital, in the ER, the ICU, and the rehab. And the goal list is we can kind of figure out what the ROSC rate for each agency is, and then what their survival to discharge and neurological outcome is. Then we can kind of compare and see who's doing what and what makes a difference. This is the standard across the U.S. I think 28 states are doing it now. Started in Emory several years ago, but this is fantastic. Currently, only transport providers are putting the data in. Hopefully, within the next year, everyone will be doing that. But it's going to give us some good input of what we're doing good and bad. Remember, we have a YouTube channel. You can watch until registry changes the rules. You can watch the YouTube channel. There's a video there. Then you take the quiz and you get Con Ed just like you were live in person until registry kind of waives that from the pandemic. No?
So you get distributive.
Distributive, but that's all. You don't need the other kind right now. Correct?
That's true, but you can always use distributive.
Okay, fair enough.
There's just a limit.
Okay, fair enough. COVID vaccines, I get questions every day in the ER from EMS and from other folks. Should we get the vaccine? I'm not going to get into the political aspect of it. I got it. COVID is a real thing. Majority of people, in my opinion, do well with COVID, the vast majority. However, there's a population of people that get COVID and have a very bad outcome. I would say that the average mortality rate in a hospital for someone admitted with COVID is about 10 to 12%. That's pretty scary, okay? And not everybody with COVID gets admitted, obviously, but COVID is real. I think, my opinion is we're all going to end up catching COVID or get the vaccine or do both, right? So if you have not got the vaccine, I would recommend it. Personal opinion, just FYI. And that's the movie that I watched before I got mine, if anybody knows what that is. It was a good movie. Education opportunities, Rocket City EM Conference in March. That's up in Huntsville. It's a 2-day conference. It is tiered. There's a hospital side and a pre-hospital side with some merging. So there are docs, nurses, and EMS providers up there. I want to say it's the 23rd and 24th. I could be wrong, but you can Google that. In March, we're in Prattville. In April, I think we're up near Madison. I could be wrong. I'll confirm that this afternoon. In May at Orange Beach is the CCTMC conference, a bunch of big words. And the short version is it's the Rotor Wing Critical Care Transport Conference. Good information. Anybody that wants to do advanced practice skills, tactical medicine, or critical care, I'd recommend going there. It's a 4-hour drive. It's a nationally known conference. Close, easy, cheap. Don't miss that either. All right, and we'll get started. So the EMT scope of practice, we used to call it the basic EMT. There's nothing basic about EMT anymore. The scope of practice is getting humongous, right? So you think about the things these guys are doing, just patient assessment, I think, is probably one of the more complicated things that we do in pre-hospital care. A lot of things these guys can do now. They can do blind insertion devices. They can assist with medications. There are more things coming down the pike from National Registry as far as scope of practice. So for the EMT, if you have EMTs that you're working with as a medic, please make sure you start working with these folks. I know that some agencies, we still good, Chief?
Yep.
All right. Some agencies, due to constraints on hiring and the pandemic and other issues, are having to go to a lot of BLS transports with ALS oversight. So the point of that is the EMT has always been the backbone of pre-hospital care, and it still is. We just got to make sure we train these guys appropriately. There's a lot of things they can do. Their scope of practice is going up every day. All right. So one of the things I want to push on the fourth Wednesday of each month is 12 lead EKGs, okay? And these things are not meant to be complicated. An EKG is a screening tool, okay? It's just like a blood test, right? It gives you some data, but not the whole picture. And I want to keep these things fairly simple. So when I look at a 12 lead, I think is the ventricular rate too fast, too slow, or okay-ish. Too fast, I think American Heart does a great job. Is it wide or narrow, regular or irregular? I give American Heart an A+ on that. The too slow, I think about three things that we got to address or think about that we don't pick up in our primary survey, right? And it's drugs, electrolytes, or ischemia. And then the scarier EKGs are the ones that are okay-ish. When the rate's between 50 and 140, and you got to look at the patient and determine if they're sick or not sick, and is it some kind of cardiac or rhythm disturbance causing the problem. And these are the ones we try to focus on a lot. This is ischemia, STEMIs, maybe some infection issues. There's some drug overdoses we can pick up in the 12 leads, and then functional use of AVR that I've mentioned several times in the past as well. Things you got to know cold as a medic is you got to be able to calculate a rate on paper. The machine does a decent job calculating the rates and interpreting, but it's not completely accurate. So I use the box method. So if I got a rhythm strip printed out, I'm going to go from one QRS to the other, and I'm just going to count the boxes and do a quick. One big box is 300, 150, 100. At that point, I really don't care anymore about the rate. It's a reasonable rate, right? And if I have to keep counting 3 or 4 more boxes, I know I'm getting down in the 60s to 50s. My mind starts to wander because I spent too much time looking at it, right? But I also recognize at that point the bradycardic, and we got to see are they sick or not sick. So there are different ways to calculate the rate. I don't care how you know how to do it, but you should be able to do it yourself on the paper and not use the machine, okay? We should be looking at our 12 leads, interpret these things, and not let the machine do it for us. Intervals you got to know, and we all learned in medic school about the PR interval, first degree heart block. First degree heart blocks are not scary, but first degree heart blocks can indicate some other issues such as hyperkalemia, so that's important to know. The QRS complex, you got to know that, because if you don't understand how wide a normal one looks like, you're not going to know if you got a tachycardia that's a wide complex or narrow complex. And I know some folks look at me and think, well, that's crazy. I can always recognize that. And in actuality, sometimes it's kind of complicated. You actually got to kind of measure it out on the more critical patients. And then the QT interval from the QRS to the end of the T wave. A lot of drugs we give prolong that QT. If you have a prolonged QT, there's a big risk of what kind of phenomenon or dysrhythmia. What can happen with a long QT? ROT, right. So you can have all kind of issues. You get torsades, you can have dysrhythmias, a lot of problems with that. So those things you got to know, okay? All right, so when I look at a 12 lead, the first thing I look at is the rate. Too fast, too slow, or okay, all right? Now, obviously, in the clinical situation, if I'm doing this 12 lead and it's printing out on the patient, my hand is also on their pulse. And that's going to give me the pulse rate, which is important, right? It's going to give me, is their skin warm and dry? Is it regular or irregular? And all that data comes in at once. I print this off and I look at it. So this rate, is it too fast, too slow, or okay? Yes, okay, right? So rate's okay. The next thing I'm going to start looking for is ischemia, things that we can fix, right? A lot of things in life we can't fix. If somebody's having a big freaking STEMI, we can get them to a hospital, do a cath, or give them a lytic, open them up, and actually make a difference. Prolong life, save life, right? So I'm going to start looking, and I look injury patterns. So I look leads 1, AVL, and 5 and 6. I'm looking for ST elevation in any of these. And obviously, if I get ST elevation of 1 millimeter or bigger in any 2 of these leads, it's a STEMI. Diagnosis made, don't need another 12 lead. I start managing the patient, moving toward the hospital, right? If I got depression in some of these leads, I'm concerned there's ischemia, and maybe there's a STEMI somewhere else, right? Or they just have a weak heart, all right? So 1, ABL, 5, and 6. Next place I look is 2, 3, and AVF. These are my inferior leads. And look for the same thing, elevation, right? Or depression. If I got 2 leads, I got ST elevation, it's a STEMI. My day is done. Diagnosis made, treat the patient, move toward the hospital. Next place I look is V1 through V4. Now these are your septal, or the middle of the heart, right? And these are the anterior leads, 3 and 4. All right, so elevation here is concerning for a big STEMI. And one of the things we talked about in the past, and we'll talk about in the future as well, is this is concerning because this is the most difficult leads to access, because you have some people who have enlarged heart failure, they have bundle branch blocks, and it kind of screws with this a little bit, and it's tough to interpret. But as a baseline, more than 1 millimeter elevation in any of these leads is concerning for a STEMI. The other place I look is the same place, V1 through V4. The difference here is if I have ST depression, that is the posterior MI. So remember, this is the front and middle part of the heart. All right, so years ago, we'd do a 12 lead, we'd look at it, and then we'd flip it over and look at these leads and see if there was elevation. All right, paper's too thick, things aren't done that way anymore. But the principle is, if you got depression here, it's looking at the back side of the heart, so it's really ST elevation. So this is a posterior MI. Sometimes the machine will pick it up, sometimes it doesn't. Some people like to get fancy. If they see a posterior MI or depression here, they'll take the leads and do a posterior EKG. Have y'all heard of that? Yeah, so that's way too academic-ish for me. So if I got a guy that's got chest pain, diaphoresis, and I see this, I call it a STEMI. If I got time, if I got 20 minutes, 30 minutes, I'm waiting for a cardiologist, yeah, I'll take the leads and move them around, put them in the back of his heart, and when you do the EKG then, you'll see the elevation. But in reality, that's just a bonus point. You don't have to do that. If you got depression in any 2, usually 3 and 4, or anywhere from V1 to V4, it's a STEMI, okay? He's going to see the cardiologist. He needs to go to the cath lab. Questions, comments, statements? Am I talking too fast? I had 2 cups of coffee. Some good coffee, though. Sweet. The last place I look is lead AVR. So old school was if you're up in 1, you're down in AVR. It tells you the leads are on correctly, and we call it a day. In reality, AVR is a pretty important lead. So if you think about which way on the 12 leads, this points toward the aortic arch where both vessels come off, the right and left coronary. So elevation in AVR is concerning for a proximal big right or left main coronary occlusion. So big, nasty area of infarct, badness can happen to the people. So elevation in lead AVR and depression anywhere else in the injury pattern. So in 1, AVL or lateral or inferiorly is a STEMI. Now, if I already had depression here, we already know it's a STEMI, right? Posterior. But up in AVR, down inferiorly or laterally, that's concerning for a big left main occlusion. Now, you may have somebody who's older, has heart disease, the 80-year-old who is now septic with a blood pressure of 60 and a heart rate of 120, and you'll see their EKG change in front of you. They go up in AVR, they get down laterally, but they're not having a big heart attack. What's their problem? They're hypertensive, they have an old heart, we know they got disease, their EKG's changing because of the demand on it. But young guy, chest pain, up in AVR, down everywhere else, that's a STEMI or STEMI equivalent. That's somebody you can call TCC and say, hey, I got this guy, concerns for ACS, acute coronary syndrome. EKG is non-diagnostic, but I want to talk to the hospital and put them in the system. And TCC would do that for you, okay? Any smiles? Yes, fake smiles. Thank y'all. Sweet. If you have issues with that, reach out to me. So obviously, the state rules are for STEMI inclusion, the machine has to read STEMI. So they're going to ask you, is it a STEMI or not a STEMI? And you're going to say no by the machine, but I want to talk to a receiving hospital. I would also argue that if you think it's a STEMI and they hook you up with the hospital, you send the EKG to the hospital, the doc says, I'm not convinced, you still go to that hospital where that doctor looked at that EKG. Because if you got a STEMI patient that you think is having a STEMI, you call a STEMI hospital, they say it's not a STEMI, but you then go to a different hospital that's not a STEMI hospital, and they're having a STEMI, what happens? It's not good, right? We've delayed care. So if you're concerned enough to call in and say this EKG is abnormal, I'm concerned, you still go to that STEMI hospital, but you just won't be a quote STEMI alert. Does that make sense? The other thing I recommend, if you ever have a patient that's you're concerned about their well-being, if they're ill appearing, EKG is abnormal, something ain't right, and you get to the hospital and there's a delay getting to a room, all right? You find the ER doc, you show them the EKG, you tell them the story. The reasonable ER physician should get up and go look at your patient, right? If they don't, that's something you can reach out to me, and I'm happy to talk to them as well. All right. This is a little diagram I stole off Google, kind of shows you what we're thinking about. So the aorta, where both the left and right arteries come off, is around the AVR when you think about the way the EKG looks at it. Inferior is usually the right coronary. That's most people. Lateral is the left circumflex. And then this is your septal and anterior. There's a nice little cheat sheet. But remember, machines do a good job at reading these things, but they're not great. We got to have physician interpretation or medic interpretation because the machine can mess up. What's wrong with this thing right here? What do y'all see wrong with that picture? Yeah. I'm not the brightest dude, but that doesn't seem appropriate, right? So again, machines make mistakes. We make mistakes. But if you got a machine doing it and then you looking at it again and not reading what the machine says, and then y'all compare, the less risk of making a big mistake and hurting somebody, okay? A lot of things we do in the ER and the pre-hospital care, I won't say it's junk, that's inappropriate, is non-emergent issues, right? But there's some things that we do we can make a difference. So, the guy with the knee pain since 1974, if we don't manage him appropriately, probably nothing bad is going to happen. The guy having a STEMI that we don't pick up on a 12 lead can have a bad outcome. So, all right, so first case. This is a young 51-year-old male, history of heart disease, chest pain for 6 hours. Vital signs are here. BLS team was on crew, 170, respirations 16. He's sat fine, pulse is 76. Got a glucose of like 200. So not too high, not too low, just right for Alabama, right? Sweet. So protocols, what are we going to do for this guy? What are your concerns, your thoughts? What do you want to do for this dude? If I can say dude. Give him a cigarette. Yeah, right. Yeah, quick history, assessment, 12-lead IV, while we're getting him worked up, right? So we teach med students to go in, do a history, do a physical, and then figure out what they're going to do. And we don't have that luxury in the ER or pre-hospital. We do it all at once. So hand is on the patient's pulse, so they're warm or they're dry, is it regular or irregular? I'm watching them breathe. I already got my vital signs, I'm sliding the IV in him, I'm getting a 12-lead pretty quick, right? It's easy when we say chest pain, we're going to get a 12 lead. But remember, we get 12 leads on anybody we think they're having an acute coronary syndrome or heart attacks, right? So when you think about classic definition of having a heart attack, textbooks talk about, chest pain, shortness of breath, leaning over, hurting real bad. To be defined classic in a textbook, that's 25% of the people that present with that heart attacks don't have chest pain. When you think about it like that, it's pretty concerning. So what other things do we want to get EKGs on? Other symptoms. So if he was nauseous, if he was short of breath, if he was diaphoretic, if he's 51 and has a history of heart disease and just don't feel right, he gets a 12 lead, right? The day you don't do that, you're going to miss something. So it's kind of redundant sometimes, but that's what you got to do. Sweet. So we have protocols that kind of guide us. I'm not a great protocol fan, but this kind of guides us. So guy with chest pain, there's some mnemonics out there. Y'all all heard of Mona, right? Mona. So that was really old school stuff. Some people talk about FONA now. Or coma. That's not funny. So what is Mona? What are we doing for chest pain for this dude? What does that stand for? What's the... Right. Yeah. Perfect. So what's the most important one? Aspirin. Yeah. And why is that?
Keeps it from causing clots.
Yeah, so it keeps it from making the clots bigger, right? So if we got a dude having chest pain and it is from a big clot in the vessel, if I give him aspirin, it jacks up the platelets so they don't stick and get bigger. So that's the most important thing I would say we give them. Contraindications would be true allergy or anaphylaxis. If they're having chest pain and they tell you that I have a history of ulcers or on blood thinners, you may want to hold the aspirin at that point in the game too, so they don't have big risk of bleeding. And this is for the chest pain population. So aspirin, very important. If they tell me they took an aspirin 2 hours before, I usually don't trust them. I give them an aspirin because a lot of folks think aspirin is also Motrin or Tylenol or Percocet, right? And it's not the same stuff. You laugh, I laugh, you know it's true, right? So aspirin, number one. What's the next thing we can think about for this dude or patient? Yeah, so oxygen. So American Heart says if their sats are greater than what, 96%, no O2. So his sats were fine. So O2 or not is reasonable for this fella. And then what does morphine do?
Decreases anxiety.
Yeah.
A little bit of vasodilation.
Yeah, a little bit of vasodilation. So in theory, has a little bit of goodness for the heart. Decreases anxiety. What'd you say?
I say it can get you 5 to 10.
I don't know why I asked Chief Ward. So it relieves pain, anxiety. They go from, oh, my chest hurts to, my chest hurts. I don't care. Can I get some more of that morphine, right? So morphine is reasonable as well in cardiac disease. Obviously, if they're hypotensive, there's no morphine, right? Cool. I would not give, well, that's another story. And then what's the N stand for? Nitro. And what does nitro do? Vasodilates, right. So if they're having a big STEMI, chest pain or ischemia or spasms, it makes that vessel get bigger, so better blood flow. In theory, they should get better. In reality, what else do they get now? Chest pain goes away, what do they get? They get a headache. That's how you kind of tell if it works, right? Because it dilates everything, you get a headache from that. What's the dose, actual dose of nitro that we give? You know what's?
0.1.
Yeah. So that's a big whopping dose of nitro. So if I was going to start someone on a drip, nitro drip in the hospital and give it through an IV, the dose is a whole lot less than that. So that's a pretty big dose. So make sure you have an IV access in these folks and you're thinking about what happens. If he goes from a pressure of 160 to a pressure of 70 after nitro, what are you going to do? Give him some fluids. You're going to use profanity. Right? You can make that eye look with your partner and go, oh, what did I just do? And you give them some fluids, right? Cool. Yeah. But risk to benefit, 50-year-old, heart disease, chest pain, I'm probably going to go ahead and do that as well. The FONA is fentanyl. So some folks don't carry morphine now, and that's fine. Fentanyl is a cleaner narcotic. Fentanyl does not cause low blood pressure. That's why we give it in trauma. It does not dilate the arteries. So it will relieve their anxiety and pain, but it's not going to do anything for the cardiac event that's going on. It's still reasonable. I'm not a big fentanyl fan. I want to use their pain as a guide. If they're still having pain after my nitro, my fluids, and my assessment, and my aspirin, it's going to make me think, okay, something weird's going on. I'm going to keep cycling my 12 leads, get serial EKGs, make sure I'm not missing anything. But a little fentanyl is reasonable to give. What would the K in ketamine? So is ketamine reasonable in cardiac issues? No. Why is that?
Increases blood pressure.
Yeah, increases blood pressure. So you're going to increase the blood pressure. You're going to increase their heart rate. You get some secretions. Some people chillax with ketamine, and some people at the low pain dose get pretty anxious and have I don't want to say bad trip, that sounds inappropriate, but have an adverse reaction to the medication, right? So you don't really want to do that. So I would avoid doing ketamine in the cardiac patients. Morphine is reasonable. Fentanyl is reasonable. There's some data out there with the cardiologist that says that if you give somebody a lot of morphine, it would jack up some of the IV blood thinners we give in the cath lab, and that fentanyl doesn't do that. So tomato, either one of those is reasonable, but I would not do ketamine. So this is the guy's 12 lead. Too fast, too slow, or okay? Yeah, I'd say it's okay-ish. The machine says 76. It's kind of hard to read. It's poor quality, but there's a point to this one. So I'm going to say 300, 150, 100. So yeah, between 75 and 100. I'm good with that. So rate is okay. I'm going to look at injury patterns. I'm looking at leads 1, AVL, and 5 and 6. See anything concerning there? Yeah, so this makes me think, okay, something's inappropriate. Is this old or new? We know he has heart disease. I don't know yet. Next place I look is leads 2, 3, and AVF. And what do we see there? Yeah, so I see some elevation. Somebody said AVF. I see a little bit there. And then I see that makes me super uncomfortable, right? Now I'm sweaty, right? This one is minimal, but there's something there. I'd argue, yeah, you could probably say that. I'm gonna go look at V1 through V4. I got T-wave inversions, but no ST depression. All right. And the last thing I do is I go back and look at AVR, and AVR is reasonable. I'm up here, I'm down here, no big ST elevation. So I've looked through those injury patterns once. Now I'm gonna go back, I'm gonna look at my intervals. I got a P wave, I got a normal QRS, my QT interval looks good. And before I put this down and make my decision, I go back one more time because some days I've worked way too long. All right. And I'm looking 1 AVL lateral, 2, 3 in AVF, V1 through V4. And now, so is this STEMI or no STEMI? Who says STEMI? Raise your hand. Who's not going to raise their hand at all? There, we got some hands raised. Very good. I like that. America, right? Who says no STEMI? Nobody's going to say that because it's a STEMI class. I mean, yeah, come on. Yeah, so I would argue that this is pretty concerning. So I would say that looking at AVF is up a little bit. I'll probably look a little bit closer with that. But in the setting of this patient having chest pain, known disease, he's up in 3, and I got these changes, and I don't know if that's old or not. If this said no STEMI, I'm still calling TCC and put them in the system. If it said STEMI, I'm gonna call TCC and put them in the system. So very concerning EKG, I agree. Cool. All right, so now, dude's got chest pain, known disease. Now he's having a STEMI. What kind of changes in our plan? So early access to TCC, we got to get him in the system to find the right cath lab. The other thing I'll think about, if the guy was on blood thinners or had GI bleeds and did not get an aspirin, now does he get an aspirin? Now he gets an aspirin, right? Because it doesn't matter if he has a GI bleed. If we don't make that clot not get bigger, he could die from that. So the only absolute contraindication now for aspirin is if he has anaphylaxis. If he says, I swell up like a bullfrog, they cut my throat every time I take aspirin, no aspirin. Otherwise, here's your aspirin, right? And the other thing he needs is he needs the D50 pads on. The biggest cause of death in STEMIs is dysrhythmias, VTAC, VFib, third-degree heart block. That's why when we first started paramedicine, or when it was first started a long time ago, you guys are the gurus, or taught to be the gurus of rhythm interpretation. There was no cath lab, there was no lytics, right? You had to recognize that a third-degree heart block, second-degree heart block is at VTAC, VFib, and you treated those things so people didn't die, right? Now we can do more, right? And then oxygen. So American Heart says O2 is not indicated unless they're tachypnic, respiratory rate too fast, or hypoxic. And the protocol here talks about indications, hypoxia, respiratory distress from any cause, so that's obvious, right? But it also kind of adds chest pain with acute coronary syndrome. So that means STEMI, right? And I would argue that we're not giving them supplemental, we're giving them pre-oxygenation before they go into cardiac arrest. It's a lot better for you guys. If you got a couple of liters of O2 on them, if they go into arrest and out to the hospital in the back of the truck and it's just one provider, you can crank that up to 8 to 10 liters, start your CPR. If you get the pads on them, you can defibrillate them if they go into VTAC or VFib. So very useful. So my point is, if oxygen is good enough for our football players, it's good enough for our STEMI patients, right? Don't. Thank you for almost smiling. Cool. The other thing about the protocols, which I'm very excited about to see in the most recent update, was contraindications. There's none in the pre-hospital setting. And they're smoking as you put it on them, right? All right. So there's good data that oxygen causes problems, long-term use, good data in the ICU. If you get somebody on high flow O2 for 24, 36 hours, it's bad for them. However, in the short term, there's no big risk for that, okay? And that's where y'all practice, that's where I practice. So if I got a STEMI, he gets O2. Now I'm not gonna put a non-rebreather on them. I think a cannula works just as well. I know that's against the current thoughts of high flow, low flow, but I think 2 to 4 liters is reasonable. And if you need more, you can always crank it up until you get an airway in those people. So dude gets to the hospital, what are we gonna do? I got 2 choices. I can lyse him, give him a lytic, or I can go to the cath lab. It depends on where I'm working. If I'm working at a place that has cardiologists, such as like at UAB, he goes to the cath lab. That's been proven to be better for these folks. If I'm working way out in the community somewhere and there's no cardiologist, I'm gonna give him a thrombolytic, opens up that vessel, buys time till he gets to the heart doctor, right? So things you guys gotta understand is can he get a lytic or not? So I was working way down south near the coast several years ago, all right? And the hospital I was working at was EMS brought a STEMI patient in, and they had bypassed a hospital that was a lot closer. And I was pretty frustrated because the dude had a STEMI, they could have lysed him and opened him up. He gets there, started talking to the medic, and this guy was sharp. He said, okay, guy had back surgery 3 days ago. All right, so at that point, I knew that guy could not get a thrombolytic. That's an absolute contraindication. You have recent back surgery in that spinal canal, and I give somebody a clot buster, they're going to bleed in that spine, they could die, or get paralyzed, bad things happen. So that medic did a great job bypassing that smaller hospital to come where we can open the vessel up with the cath-ab. So these are things y'all should understand. There is a cheat sheet in the protocol that in theory the state wants you to fill out on every STEMI patient. I would say go through these, know the questions to ask. This information should be transferred over to the doc at the hospital when you get there, okay? State says do the form, so do that, but at least get the information down, put it on your glove, give it to the doc when you get to the hospital. And this information should go to the doc because he's the one that's going to make the decision if the patient goes into cardiac arrest. Do we lyse him or what do we do? Clot buster drugs are different than blood thinners. So a blood thinner makes this clot not get bigger. If I give a clot buster, TPA, it's the same drug that we use for strokes, or TNK is a single dose, a little bit easier to manage. All right, it makes this clot go away. So this breaks apart, floats downstream, and restores blood flow. The problem, though, is it's not specific for the heart. If there's a clot in the brain from a recent stroke, that breaks up, they bleed in the brain and they die. If there's a clot in the gut from a GI bleed, same thing. So there's some risk to this drug, and you guys that have STEMIs and manage them should understand what those risks are to make the right decision. Questions, comments, statements within reason? All right, sweet. So this is this guy's heart cath. So he was having an inferior. I agree with you. I'd probably call that in that setting. It was a millimeter or a little bit more in lead AVF, but lead in 3, but 2 was really big. 2, 3, yeah. So big RCA. So that's the right coronary vessel. So you can see this is his vessel. They put a wire up in the groin, they squirt dye, take an x-ray, and you can see there's blood supply going this way, but you can also kind of see the outline here. That's his right coronary. So this part of the heart is not going to get blood supply. The longer that takes to get opened up, the more that right side of the heart will be damaged. So if this is not fixed soon, they've had right-sided heart failure. Those are the guys that get a right ventricle, they get heart failure, they get volume overloaded. So the guy that used to go out and do things and be active in life cannot do that anymore. So picking up that STEMI, we can fix it. And you can see here, much better flow. Look how much that artery supplied. See the difference? Pretty cool. Good news for us as well is hospitals are really excited about EMS now. For years, I'm not going to say that. So, but cardiologists are excited about the work that you do. They want to look at your charts. They want to be involved now because in the past we had numbers, metrics, right? So the goal was from door to EKG is 10 minutes at the hospital. From the door to go into a cath-ab in a STEMI is 90 minutes. And there was 2 reasons for that. One, time is muscle. We want to get these folks' vessels opened up, save a life, and also save the quality of life, okay? Well, American healthcare is based upon money too, right? If you haven't known that, I can give you a text later how that works. So if we don't, if the hospital does not meet those metrics, we do not have the ability to bill and get as much money from Medicaid, Medicare, as I'm told, right? So the hospital is very excited about making sure we get these numbers down, these time frames. Now the Medicaid, Medicare, CMS is looking at from first patient contact with you guys to cath-ab. So it was 90 minutes door to cath-ab. Now it's 90 minutes first medical contact, which is you. Dispatch them on scene to cath-ab. That changes everything. That pushes the envelope back. So we're looking at the hospital now. We're looking at your first medical contact. We're looking at when you make contact with the patient to when you look at that EKG. And if that EKG is a STEMI, when they get in the system, and then when they get to the hospital and go to the cath-ab. And the cool thing is we're still seeing pretty good numbers around this 90 minutes now. So the point is, you guys are doing a great job. Okay, my goal is that someday in the future that we are able to turn off the interpretation of that 12 lead. And so you run a 12 lead and you look at it and you make that decision. Okay, you guys are the gurus of 3 leads. You should be the gurus of 12 leads as well. All right, and we're going to get there one day. I think that's good for all of us. I know there's some places out west that's doing that already. Not West Alabama, but out further west, past Mississippi. All right. Thank you for smiling.
Hey, Doc, we do have a question online.
Yes, sir.
It says, for ALS non-transports who are waiting on the transport unit, which is a better option, V4 through V6 right or V7 through V9 posterior when you suspect a posterior wall infarct?
So for me, for the posterior, I'm not going to do a posterior EKG. I'm going to get the regular 12 lead, and if there's ST depression in V1 through V4, you talk to TCC and say, I think this is a posterior MI. If the machine says it, you're great. If it doesn't, you have that EKG sent to the hospital that has cath capabilities that you want to go to, and that doc will look at it. If they ask for a posterior, that's reasonable, but I would not do that on scene. I would do other things first. I'd get a second IV, make sure the pain's controlled, on-9 med control, TCC, looking for a cath lab hospital. So I'm not a big fan of doing the posterior EKGs just because if I got a person with a depression in V1 through V4 and I do a posterior and it still looks good, I'm still going to call a cardiologist because there's still the big risk they're having some kind of big event. The other thing that may help us in the near future is with the hospitals being excited about y'all's records, the hope is to move forward again with the talks of integrated healthcare records for the region. And then you could say, okay, I got John Smith here with this EKG. I'm concerned for posterior. You go to your laptop, you pull up his record, and you look at his previous EKG, and it was already there. Then you can think, okay, maybe this isn't a STEMI. Maybe this is a normal EKG, and you feel better. He still gets evaluated, but the stress is not as much. Does that make sense? Versus you pull up his old EKG, and his old EKG is stone cold normal, and now you got this depression. Now you're sweating because you know this is abnormal, this is new. He's going to the cath lab.
So the other question we had was, could you speak a little, so we're all pretty familiar with what happens in hospital for STEMI patients. Could you speak a little bit about how non-STEMI MIs are treated?
Yeah.
Why are we making a differentiation from STEMI and non-STEMI?
Right, so STEMI is basically the EKG says you're having a heart attack, but that does not get all the EKG, all the STEMIs that are out there. So I've seen people with normal EKGs that have a blood test called a troponin that looks for heart damage that is sky high. So you can have a vessel that occludes that doesn't jack up your EKG, and I don't know all the numbers. But current literature in the cardiology stuff talks about people who have chest pain, anginal chest pain, elevated biomarkers, blood tests that show the heart's being damaged in a normal EKG should still go to the cath lab to figure out what's going on. So a STEMI is the EKG shows a STEMI. In STEMI means that they have blood tests that show they're having heart damage, but the EKG is not a STEMI. It's that simple. Ish.
Right, so
you can no.
What a non-STEMI is.
No.
Non-cardiac causes of chest pain.
Correct. The way you diagnose the in-STEMI is a blood test, which you cannot get. Now, some of the flight programs can get a bedside troponin test to use, and that's a reasonable thing for critical care or way rural medicine. That's reasonable. But there's no way for you to diagnose the in-STEMI. So 50-year-old, history of heart disease, normal EKG, having chest pain, you got to think they're having an in-STEMI, still having heart problems, even with a normal EKG. Or normal EKG does not get you out of the woods. Did this play? I can't tell. Did that play at all? Okay. Did y'all see I showed it last, I just jacked something up that time. I showed this. Oh, there we go. So this is, somebody sent me this. I'm appreciative of them. This is somebody in the cath lab, and they inflate the balloon to open the vessel up, and you see the ST goes down. They deflate the balloon, and the ST segment goes up again. Y'all see that? So that's just changing of opening up that vessel. So that's pretty cool. The other thing I would say is that dynamic EKG changes are concerning. So if you get a 12 lead on somebody that says STEMI, and then you give them nitro, aspirin, fluids, they start feeling better, and you get a second EKG down the road and it doesn't say STEMI, for me it doesn't matter. Their EKG should never show a STEMI, right? Should never have those changes. All right, so maybe your nitro, maybe your aspirin helped them a little bit, they go to cardiologist. So my advice is once you get a 12 lead that says STEMI, you're done. That's the one you send, that's the one you show the docs, you're done. If you get a 12 lead on a patient you're concerned about and it does not show STEMI, you keep getting them. 12 lead, 12 lead, 12 lead, 12 lead until it does, because that buys you a lot of time, right? Sweet. Yes, sir.
As far as BLS departments, we don't have a machine that will do EKGs now. We just got
Yes, sir.
AD and that's it.
Right.
We get on the scene, the guys complain about chest pains, so forth, so on. He has nitro. Would you recommend go ahead and give him one of his nitro if he hadn't taken one? And an aspirin while we're waiting on ALS, whether it be Springle or Oval or RPS, whoever it is?
Yes, sir. Yes, sir. So the question for those online was, BLS unit unable to do a 12 lead because they have an AED and you got a guy on scene with chest pain. Is it okay to give them nitro if they have it and aspirin if they have it? And I would say yes. Now, obviously with the nitro, if their blood pressure is 100/50, if they're hypotensive, if their bradycardic rate's less than 60, if their tachycardic rate's greater than like 110, 120, I'd probably avoid that nitro. But yes, I would help them with their nitro, help them with their aspirin, yes. Now I know some parts of Jefferson County, even BLS agencies, got some grant money and got some life packs. And those things, I'd recommend if you have those in your BLS, you learn how to do a 12 lead. And that there's no way I expect an EMT or an AMT to read the 12 leads. That's just, you haven't had the training yet. But that one, you still print it off, you got the interpretation, you send that to TCC or take a picture of it. And if it says STEMI, you know that you tell the transporting agency that, and they're going to upgrade the care and get you moving. Or maybe you call a flight program to come out that way as well. And that next class we'll do, I'll show some EKGs that I got from BLS agencies that did a 12 lead and then called a flight program, and we had a pretty decent outcome too. So, cool. We've already shown that, I think. All right, so let's talk about some hypertension for a second. So hypertension, from an ER standpoint, we think about hypertension, is it a medical emergency or not? That's the question. Everybody in Alabama has hypertension. I'm not going to make you raise your hand if you have hypertension, right? If you're over the age of 14, you probably got it, right? At least in the Deep South. So things I think about with hypertension as far as are we concerned or not concerned? Is it a hypertensive emergency? And the way we define that is end organ failure. So if we have somebody who is hypertensive, all right, and they have a problem causing the hypertension, we fix that problem, not the hypertension. For example, if I got a patient who is 24 weeks pregnant with a blood pressure of 220/130, what's going on with her? She's eclamptic, right? So I don't need to think about, okay, she has underlying just hypertension, I'm gonna treat that. No, we need to get her moving, control her blood pressure at the hospital, but we need to fix that pregnancy issue, right? An aortic dissection is hypertensive. They're hypertensive because of the dissection, because parts of the heart and the body are not getting blood flow because the aorta is being torn. So we gotta fix that. We don't fix the blood pressure, right? And then pulmonary edema, hypertension, we treat the pulmonary edema. Type 1 myocardial infarction. All right, so that's what docs trying to be fancy. That's a STEMI, okay? So type 1s are STEMIs. So if somebody's having a STEMI and they're hypertensive, I'm not going to give them labetalol or Cardine, which y'all can carry now. What drug would I give them? Somebody having a STEMI, chest pain, hypertensive, what drug do we give them? Nitro. Yeah, that fixes the problem, right? So we treat the underlying cause for a lot of this hypertension, okay? Some of the other things that we get concerned about, end organ things that you can't figure out in the field without labs. It's acute kidney injury, so they have new kidney failure, or a type 2 myocardial infarction, and that's the NSTEMI. That's the guy who has signs of heart damage by blood test, but not EKG, okay? So hypertension is a hypertensive emergency, and we treat the underlying cause first. If we can't figure out the underlying cause, then we go back and treat what's going on. So this EKG, this patient, their blood pressure is 170/102, okay? And they're having a STEMI, right? So some people would argue they're having a hypertensive emergency. Should we give them labetalol by our protocols in the state, right? And the question of that is probably no, right? This is a STEMI, type 1 heart attack, right? They're hypertensive. So we treat their hypertension with nitroglycerin, right? Nitro every 3 to 5 minutes. until they get hypotensive or the pain is resolved. All right? Anybody know what that means? Sorry, inappropriate. So, 12 lead we saw earlier is having a STEMI, hypertensive. The question is, protocols talks about control the blood pressure and severe hypertension. I would say that's fairly elevated, 170 over 102, but I'm not going to give this dude the beta law. I'm going to give him nitro, okay? So the beta law was category A in our state. You can carry it. It doesn't require a refrigerator. It's not an expensive drug. There's some agencies carrying it. But I would recommend that you think about the underlying cause of the hypertension and is it going to make them better? So the beta law is a beta blocker. Beta blocker use in STEMIs, we do that in the hospital. We try to get a beta blocker on board within 24 hours. Years ago, we'd give them beta blockers in the ER. So if somebody came in 15 years ago having a STEMI, we'd give them aspirin, start a nitro drip, and you give them a beta blocker, 5 milligrams of metoprolol, and you repeat that every 3 to 5 minutes. And the thought was it slows heart rate, lowers blood pressure, so the heart does better, not as much strain on the heart. But in reality, what it does, it slows heart rate, lowers blood pressure. So now that vessel that's occluded in the heart is not able to get the blood supply that it needs because now we got an occluded vessel. That blood pressure is 170 over 102, heart rate 70. I dropped the blood pressure to 100 systolic. I dropped the heart rate to 50. And it's hard to pump blood through the coronary arteries as well. And these folks went into cardiogenic shock. So I would recommend this patient gets nitro and not the beta law. What about this patient? This is an older guy, left-sided weakness, blood pressure 210 over 120. Does he get the beta law in the field? No. I hear a no. Do I hear a yes anywhere? No one's going to speak up. I would say, yeah. Now, why not? Why does he not get blood pressure control? Yeah, he's having a stroke, right? So he's got poor blood supply to the brain, right? So he's probably hypertensive to keep the perfusion to the brain so he doesn't have a worsening event, all right? So there are two types of strokes. There's ischemic, just like we have at heart attacks. You got a stroke that is a blood clot. So if this dude's having an ischemic stroke and I give him the beta law and I drop his blood pressure to a normal Alabama 160 over 80, all right, the part of the brain that was being perfused by this blood pressure now gets no perfusion and his stroke gets worse. And now he goes from having a 3-week recovery to a 6-month recovery or no recovery. The caveat, let's say he's having a stroke that's hemorrhagic. So now this vessel busted and there's blood in the brain. In the hospital now, I will control his blood pressure because if I keep his blood pressure high, it perfuses kinda the part of the brain that's not getting blood supply, but not real well because there's a leaky vessel. If I lower his blood pressure, I stop the bleeding and make him better. But how do you determine if they're having an ischemic or hemorrhagic stroke in the field? You can't. Right? So there's some telltale signs that clinically you kind of look at them and go, it's probably hemorrhagic. But my experience is that's still probably a flip of the coin. It's like, I think that's hemorrhagic, but I'm not going to lower the blood pressure until I see a CT scan, which you can't get in the field. So remember, any drug that you have that you can give, there's a risk and a benefit. So if you roll the dice and this dude's having hemorrhagic and you lower his blood pressure, you may have helped him a little bit. But if you roll the dice and you're wrong and he's having ischemic, you just screwed him. So the beta law is a relatively safe drug in the right conditions, but a lot of the conditions that we see in the ER and pre-hospital are not those.
So, Doctor, when would be a good time? Are you about to give us an example of when might be a good time for pre-hospital use a beta blocker?
Sure. We'll get there. So this is a person with blood pressure 180 over 70. Respirations are fine, well, not fine, 32. Heart rate's 116-ish. That's their EKG. So rates too fast, too slow are okay. I say the rate's okay. We can look at injury patterns. We got some depression there. 2-3 and AVF. Nothing super scary. V1 through V4. AVR looks fine. I'll look intervals. Maybe some P waves. feels regular when I touch the pulse. QRS is wide. I look over here, so QRS is wide. I'm gonna think a bundle branch block. I know we talked about that some in the past. So I'd say it's probably a left bundle. So no scarbosa, a lot of big fancy words here, right? But the short answer is not a STEMI. All right, complaining of a headache and this blood pressure. Does he get labetalol? Yes, no, or no comment? No comment, I like that, it's good, yeah.
His only complaint is a headache,
Yes, sir.
no other neurological issues?
No, sir. Moves everything, talkie-walkie, just got a headache.
Good, but probably not.
Yeah, so I would say probably not too. Yeah, you could technically, all right? He's hypertensive, all right? But I would probably avoid this. And the one reason I would avoid on this dude is this right here. So the question is, what number is hypertension or hypertensive emergency? And it, depending on which physician group you trained with, gives you the answer, all right? So the ER literature talks about 180, actually, about 220 over 120. Those numbers we get concerned about. So if I had somebody that showed up in the hospital, headache, blood pressure 220 or 218 over 118 with a headache, I'm probably going to get a few labs, make sure I'm not missing something. I'm going to give them some pain medicine, treat the underlying problem, and see if the blood pressure gets better. All right? Now, family medicine docs, internal medicine docs, they freak out over these numbers because those numbers are bad. But the goal of emergency care is to treat the underlying problem, all right, such as heart attack, stroke, things like that. And then we get concerned about going home with blood pressures higher than this, okay? So strokes, we talked about some, excited delirium. If I got the guy that's butt naked running down the street, you finally capture him, tackle him down, and his blood pressure is 240 over 140. Is he going to get labetalol? No, he's going to get what? Ketamine, exactly. Treat the underlying problem, his blood pressure gets better. If I got the 40-year-old MCC who now has an open femur with a blood pressure of 220 over 120, what's he going to get? Fentanyl, right. So treat the problem before you treat the blood pressure, right? End organ failure would be, we talked about the chest pain, the STEMIs, but we treat that with nitro, talked about strokes. Visual disturbances, so somebody with a blood pressure 230 over 130 who now has vision changes, okay? Maybe some slurred speech, a little bit confused. That's somebody that's reasonable to think about controlling their blood pressure, all right? The labetalol is safe. It has both alpha and beta properties. So that means that if they just smoked a bunch of crack, right, which is all alpha-ish, and well, alpha and beta, smoked a bunch of crack and you give them the labetalol, you're probably okay. Versus if you had something like a Metoprolol, which is pure beta, if you give them that, you slow the heart rate down but increase the blood pressure. But that's getting way too deep in the weeds there.
So you're talking about the patient that had visual disturbances with severe hypertension?
Yes.
So could that also be an ischemic stroke?
It could be an ischemic stroke. Yes, it could. Yeah. So the way I would manage this patient in the hospital, if they came in, blood pressure 230 over 130, and their vision's kind of blurry, they don't feel well, I'm going to get a few labs, check a glucose on them, all right? Probably get a scan for the head. I'm going to probably treat them with pain control initially and see what I get the blood pressure to, and then determine if I'm going to use labetalol. But of all the cases we talked about, that was probably the most appropriate one for labetalol use. So I'm not against EMS using labetalol, but you guys got to understand there's some risk to that, because if they were having an ischemic stroke and you give the labetalol, you can have problems. Yeah. Some folks are carrying it now, not everybody does. So I'm probably preaching to the wrong choir. Let's see, this is a 64-year-old male, history of AFib, COPD, now cough, weakness, chest pain, sore throat, my ankles hurt, got a bump on my butt, multiple complaints. You know how it goes, right? You get there for one thing and the story just progresses and you start kind of thinking about the next football game. What are you going to do? Vital signs are noted there. Let's see, do I have a bigger EKG? Yeah. Too fast, too slow, or okay? I'd say it's a little fast. So it says 140. I'm going to go and find a QRS that's on a box so I can see it better. So 300, 150. So it's 150 to 175 by my math, 148 by theirs. So I'm going to say it's a little bit fast. So the next thing I'm going to do is I'm going to look at my QRS. My QRS It's a little bit wide, isn't it? Yeah, all right. And then I'm gonna get my hand on the pulse and I'm gonna feel the pulse. Is it regular or irregular? And then I'm gonna go through and look for injury patterns. So I got some T-wave inversions. That looks pretty funky, but not a STEMI. V1 through V4. I'm up a little bit there, but that's the only place. Not super scary, all right? So what is this? Yeah, so it's AFib RVR, I would say, it's because it's irregular. The thing that kind of bites you some is the complex is a little bit wide, so it's probably some aberrancy, but rate's a little bit too fast. So what can you do to treat this guy? So blood pressure is fine, heart rate is up. What we can do for this guy? What'd you say? I missed it. I'm scared to ask. Never mind. I don't want to know.
And the low RPM.
Help me, Lord. So I would say that the rate is too fast. All right. So it kind of goes against the AHA treatment of narrow versus wide because he's a little bit wide complex. Yeah, blood pressure is like 140 over 60. Respiration's fast, but not hypoxic. So. Yeah. 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 So I agree. So kind of treat the underlying issues, right? So a little O2 is reasonable. All right. I'd probably start a line, get a quick AccuCheck. Not having a STEMI, but we think AFib RVR. So we're going to treat the underlying cause. Remember, AFib with a fast ventricular rate is the sinus tach for those that have AFib. So, you know, if I go out and I caught COVID and I was hypoxic, I'm going to be tachycardic and be in sinus tach, right? If I had AFib and I got COVID and got hypoxic and tired, I'd be in AFib and RVR. So you want to treat the underlying causes for that. So oxygen is reasonable, IV fluids is reasonable, okay? There is the drug Cardizem, it's Cat B, that you can give. I think it's got to be refrigerated unless you get the big bag of it. But you can't, what now?
There's a powder.
There is a powder? Perfect. So some folks are carrying this. It's a calcium channel blocker, can be used for rate control. But remember, sometimes that when you think about rate control with these folks, cardiac output is heart rate times stroke volume. So if their volume down in an AFib RVR, and then I slow their rate down a little bit, they can make them worse. So food for thought, okay? Now, separate scenario. Now they got a blood pressure of 70 and they're altered. What are you going to do for those guys? Ride the lightning, okay. Yeah. Yeah, so synchronized cardioversion is very reasonable for them, okay? What are the risks for synchronized cardioversion in somebody with AFib?
Turn into not AFib.
Turning into, right. So if you got the candles, you're probably okay. Where do they go? The candles were up there. So if you got candles lit, you're probably not going to get that ROT phenomenon. You probably won't go into VTAC or VFib. That's poor form if you do. Very poor form to defibrillate them, so you got to make sure you got it on sync. Other risk, besides not going into AFib, would be, I would think about, remember, folks with AFib can sometimes have blood clots, so you can throw a clot, they can have a stroke, right? Those are risks, but those risks are fairly limited in the setting of a blood pressure of 70 and altered mental status. I think AFib RVR, who are symptomatic hypotensive, those are the more scary patients to manage for me because most of them have underlying heart problems. And sometimes even when you shock them, if you get them out of AFib, if they're in AFib because they have heart failure and the heart's got to beat fast to perfuse the body, and now I take them from a heart rate of 150 to a heart rate of 80, they're going to bomb the pressure out as well. So anybody in AFib RVR that you cardiovert or give a medicine to, Cardizem or whatever you got, be thinking in your brain, what are you going to do if they get hypotensive after that? So you synchronize cardiovert this guy, and now he's in a sinus rhythm rate of 80, and his blood pressure is still 80 systolic. You can be opening up the fluids. You can be thinking about push dose epi. If you have access to critical care stuff, you have like milrinone or dobutamine, you're going to do that as well. So always be ready for the worst case scenario because at some point in your life, you're going to get it, right?
So Doc, which one do you think is safer? Do you think calcium channel blocker or synchronized cardioversion?
So I think at a blood pressure of 70, you cannot give a calcium channel blocker. Now, in the ER sometimes there have been people who are kind of borderline. So I'm thinking AFib RVR, what's going on? Blood pressure of 80, 90 maybe. I'll give them a little bit of Cardizem, but I do it very slowly. But again, that's why those people are very scary to manage. And that's somebody that I know has probably got AFib, probably has a big clot in the ventricle or the atrium. And I know if I cardioverse them, there's a big risk for a bad outcome. So those folks, that's why they're scary to manage. AFib is probably one of the more common dysrhythmias you're going to see. Most of them are fairly stable. The unstable ones are very concerning. I would do fluids on this patient. If they had a fever, they get fever control. I'm looking for reasons for them to be tachycardic that I can fix. All right. Another drug that's not listed in the stepwise protocol that you can use on somebody like that, if you don't want to synchronize cardiovertem or you can't synchronize cardiovertem for some reason, is amiodarone. Amiodarone is a great drug for any kind of tachydysrhythmia. So obviously you got to call med control. That's not in your list, but just like magnesium that we use now for respiratory problems, years ago we did not, but you can call in and get it, same thing. So I've used amio and AFib RVR. They've been hypotensive in the past that I did not want to synchronize cardiovert. And it's 150 milligrams over 10 minutes, and that seems to help pretty good too. So just another tool in your box that can help these folks. Other things in the hospital that I can use, something called Esmolol. It's an IV drip beta blocker. So if I give them Esmolol and they get hypotensive, I stop it and the medicine's gone like in a minute. Great drug. Metoprolol is a long-acting beta blocker. Some states carry that. I'm not a big fan. Has a long half-life. The other problem with that is the dude's been smoking crack and I give him Metoprolol. I'm gonna slow his heart rate, but increases blood pressure, and that's a bad thing for him. DIG is an old drug you may learn in medic school, digoxin. We don't use a lot of DIG anymore. There's a new drug called Corvert, and I've used it maybe 3 times in the past couple of years, but it is works sort of like amio, but it's a one-time dose, and these guys will go from AFib RVR to sinus pretty quick, and unless they got a really jacked up heart. And it's pretty cool to watch. But the risk for this drug is just like synchronized cardioversion. Just a classification of drugs. So 24-year-old female that, how did the cat picture get there? I don't even know. Ultra mental status, she's breathing kinda-ish, but has a pulse. What are the goals of care for this patient? Make him breathe more than ish. Don't get stuck by that needle, right. Don't get stuck by the needle. Roll her over, open the airway, suction if need be, NPA, maybe a little BVM. Somebody's getting a line, getting an AccuCheck on her as you're going to give her what drug? A little bit of Narcan, nasal, IM, IV, whatever you got. Narcan reverses the opiates. There's all this opiate receptor things, but the short version is that it messes with the respiratory center of the brain. So we want to reverse that. The reason I mention this now is this past weekend, there were 4 patients brought in from the same establishment. I won't mention the name of the establishment, okay? That came in, they got Narcan, they got 2 of Narcan in the field, they got another 6 or 8 of Narcan in the ER, and they woke up enough that they were breathing. They never became completely awake. They watched them for about 6 hours, and then they all went down at the same time again and quit breathing. So there was something in their medicine. So Narcan has a half-life 30 minutes to 4 hours. If you shoot up heroin, Narcan is probably fine to give, and the patient can wake up, say, I don't want to go to the hospital. You can PRT them. If they mix their heroin or something else with something stronger, with methadone, some long-acting opiates, something like that, Suboxone. Well, Suboxone has a little, yeah, but anything long-acting can really mess with you. My practice in the ER is I usually, if somebody gets 1 dose of Narcan, I watch them for 4 hours. If they get 2 or 3 doses, I put them in observation for 24 hours to make sure we're not missing something. But these guys, one of these guys only got 1 dose of Narcan and woke up enough to breathe. And again, that's the goal, make them breathe, not make them wake up, crap on your stretcher, get mad at you, call you mama names. You just want them to breathe, right? And then they all went down at the same time. So that tells me they all shot up or snorted at the same time. So just be careful, is why I brought this. Be careful. There's some drugs out there that last longer than we think now. My general rule with Narcan, if somebody wakes up from Narcan and they want to refuse treatment, the question you ask is, were you suicidal or just trying to get high? Because this is American healthcare, right? If they're just trying to get high and you explain to them that you can quit breathing and die, and they go, I'm cool with that, they can leave. They can PRT, that's reasonable. Well, it's not reasonable, but they can leave, right? If they wake up and they're like, oh, my dog just died, my girlfriend left me, I don't want to live, and they shut up, that changes everything. They're suicidal. State law says now you got to come to the hospital. All right. So just be careful. There's some long-acting stuff out there that's pretty concerning.
Doug, somebody texted in, want to know if you've seen more GHB recently.
So
there's been a resurgence.
Yeah, so it's been, yeah. And the other thing is a lot of people do GHB, heroin, Ativan, benzo, alcohol, whippets, ketamine. People mix everything together, so there's no way to tell what's going on, right?
Hey, Doc, I have a question too.
Yes, sir.
There's also the gas station opioid, Tianapine.
Yeah, I can't say it either, yeah.
That one.
Yeah.
In the research that, I know that the ADPH was trying to get it outlawed, and there was some issues where in November, there was some litigation, they had to pull that. They were trying to classify it as a class 3, I think it was.
Yes, sir.
Is it responsive to Narcan?
Yeah, so I'm not sure about that. I honestly don't know the answer. I think that if somebody is taking it and they're not breathing, you give the Narcan. Yeah. Risk to benefit, if they're not breathing, there's no risk to Narcan. But I'm not really sure.
It talks about it's a synthetic, or it acts on the opioid receptor, so that's why I was wondering if the Narcan would. So
it may. So there's some cross reactivity. So, but yeah, I think if they're not breathing, I would try the Narcan. The only risk to Narcan, in my opinion, would be a couple of things. One, you wake them up, they're pissed off, they want to fight you, you got issues there. And then there's a small subset of people that get Narcan that when they wake up, they go into pulmonary edema. And it's usually the folks who are doing heroin. And the way you manage that is not give them more Narcan unless they quit breathing, is you treat them like pulmonary edema. You know, BiPAP, they probably don't need nitro, they're not hypertensive, but BiPAP, high flow oxygen, and set them up.
At what point do you stop giving Narcan? Like you can't give it and give it, not being responsive with it.
Yeah, so if chick is sitting there and I open their airway, NPA, gave her Narcan, she doesn't get better, give her another dose of Narcan, she doesn't get better, I'm going to bag her and just intubate her. Okay, so I think that, you know, the state says you can go up to 8 milligrams. The only way I would do that much of a dose is if I give somebody 2 and they breathe, and then 5 minutes later they're not breathing, then I'll give them 2 to make them breathe. But if you're not getting a quick enough response, you manage the airway. Yeah, because that means either they got a big dose of our opiate on board, or they got the opiate, the benzos, to something else. Other thing I wanted to mention, American Heart talked about Lidocaine coming back out, is one of the first line drugs for VTAC, VFib. In my brain, it never did go away, but it's out there. And I want to mention that, remember, Lidocaine, we used to use it for post-cardiac arrest to prevent VTAC, VFib. A lot of uses. Now I say it's only recommended really for cardiac arrest. For using it for PVCs, be careful. So this patient here, you get a 12 lead, a 3 lead, they're throwing PVC. Oh, that's not good. Don't touch the screen. They're throwing PVCs, right? So what happens if I give this guy Lidocaine for his PVCs and I stop the PVCs? This is right. He is now bradycardic. So now I took a guy who's probably getting a little bit of perfusion from these beats, who's already got a slow heart rate in the 60s. And if I take this out, now his heart rate's probably in the 40s. So I just made him worse. So remember, every drug has a risk and a benefit. Lidocaine's coming back into style. Just be careful with it. And I'm talking way over today. All right, this take about 2 minutes, 2 or 3 minutes, Chief, if that's okay. And then we'll come back and talk about some endocrine emergencies. And thank you for smiling. Sweet. All right, so we're going to talk about some diabetic emergencies. We got about 40 minutes. We'll go through this, and then I'll talk about questions. So when you
Here's to you, Dre.
So when you think about diabetes, there's a couple things we talk about. The 3 things I think about is DKA, hyperosmolar, non-ketotic. There's a new phrase for it, but I can remember the word honk. Hypoglycemic complications, and a couple of key points. Remember, diabetes is everywhere. If you look at Alabama, you know, we are in the Bible Belt, but we're in the septic belt, the obesity belt, the diabetes belt, the I smoke too much crack belt. We got a lot of belts around here. But diabetes is pretty prevalent. If you have not run on a patient with diabetes, you do not work in EMS, right? Stats in the 1950s, people died from diabetes pretty early on. 1 in 5 died within 20 years. Actually, it was probably more than that. So now with the treatments, the therapy with insulin, folks can live a relatively normal life. Before insulin was found, I think in the 20s, people just died. Type 1 diabetes, we all learned the type 1 and type 2. There's probably numerous types, but the pathway is kind of separated into two forms. So type 1 is the ones that do not have insulin anymore. So it's some kind of autoimmune destruction of some pancreas cells. So they make little or no insulin. And you know, insulin does a lot of things. It regulates our glucose levels, but it also helps the growth. It makes steroids, does protein synthesis. So folks that are truly type 1, kids who are type 1, you'll see them kind of slowly not gain weight, they not grow well, there's some growth retardation, etc. And then we go, oh, well, crap, they're diabetic. That's the problem, we have these issues. So insulin is very important for a lot of things, not just to consume our donuts, even though I do like donuts, right? 1922 was the first dose of insulin was given. And if you go to Wikipedia, my source of all medical knowledge, you'll realize that it's pretty impressive. You know, these kids would be put in these hospitals, big bays, and they would just waste away and die. And it was almost like magic. They gave insulin to the first kids. They just woke up and started talking. So pretty cool. But now we have long-acting insulin. We have intermediate-acting. We have short-acting insulin. We have pumps, sliding scales, all kind of things. The way insulin works on the cells for glucose is insulin attaches to a cell wall. That cell wall jacks something up and shoves a glucose transport membrane in there, and glucose goes in. And when glucose goes into the cell, it can make proteins and do things. So when glucose goes into the eyeball cell, it makes the cell so you can see and do things. Into a kidney cell, the same way. When glucose goes into a muscle cell, you get big pumped and things like that. So very important stuff. The side effects of diabetes, the things that get you, is hyperglycemia. It's bad whether it be acute or chronic. There's two schools of thought. One school of thought is that chronic elevated glucoses jack up cells and make you have long-term complications. And then there's another school of thought that now when we see a lot of type 1s and type 2s is that folks who have changes in their glucose, so your glucose is 480 at lunch and then 70 at 3 o'clock because you took your insulin, and then again 900 before you go to bed because you had 3 beers and a dozen donuts, and at 60 in the morning, that strain messes up the cells. There's a little bit of both probably. And the way that does that, remember, glucose is a big freaking molecule. Anybody ever push D50? Does it go in easy? No, it's a big freaking molecule, right? It does osmosis. So if you think about if this is the vessel, right, and this is the cell, whether it be muscle, eyeball, brain, whatever. If you got big glucose molecules in here, it pulls water away from the cell, right? So water goes to that big glucose molecule. This cell shrinks and shrivels and gets strained because of that. So even if you do have insulin in there and you can get energy in there, the cell doesn't work well because it's dehydrated. Right? So if this cell is a kidney cell, it jacks up the kidneys so that your kidneys are unable to filter things. And then the filtration device of the kidney starts breaking away, and people with long-term diabetes get renal failure. Then they go on dialysis. There are all kinds of issues with that, right? If they have neuropathy, so that's where the diabetic says, I can't feel my toes, I burned my foot 2 weeks ago, didn't even know it till this morning, right? And that's because the elevated glucose pulls the water out of that nerve cell, and that nerve cell cannot conduct feeling, so they have problems. So they get neuropathy, so they can't feel their fingers and toes with poor control. They also get neuropathy inside their body, so they get something called gastroparesis. The GI tract doesn't work well, so food doesn't go through the GI tract. It goes very slowly, and these folks with bad diabetes get gastroparesis, and they show up. They call you guys, and they're nauseous, they're vomiting, they can't keep foods down. We give them Zofran, give them antiemetics, and it doesn't fix the underlying problem, which is the nerves in the gut don't work to push the food down. So I joke about diabetes with a lot of issues with that. You get renal problems, you get neuropathy we talked about, and this affects us when you think about heart disease. So you get this diabetic who is now tachycardic, the glucose is high, They don't feel well. They have no chest pain. They have no chest pain because the nerves that transmit feeling from the heart are jacked up because of their underlying disease. So things to think about, right? The other problem with this is diabetes is a chronic stressor. These cells are shriveled up, dehydrated, right? When you think about normal vessels in the body, they have cells that kind of hang out on the side to get ready for an injury. So if you were to get stabbed, these cells flop off the wall, they come through here, and they clot this off so you don't bleed and die. With diabetes, because these cells are always stressed, these things don't hang on the wall anymore. They're always floating around, jacking up good nerves, jacking up good things, and causing your body to be in a chronic state of crisis mode. And just think about how we act as a system with this pandemic. We're in a big crisis mode. Everybody's working 3 jobs. We're all tired. We're worn out. We miss things. The body's the same way under this chronic stress, okay? So hyperglycemia is bad. I was going to draw on 3 different screens, but I didn't, so I'll just keep going through. Type 2 diabetes, this is for Chief Ward. I think he watches this on Netflix. Type 2 diabetics is different. So they have insulin, but they have insulin resistance, right? So what happens is you have insulin in the body, insulin tries to go to these cells, but for some reason, these proteins are jacked up and the insulin cannot attach. So you don't make the proteins, you don't get glucose inside, all right? And that's in addition to the hyperglycemia that makes this shrivel up and these cells not work good. So it's a relative insulin deficiency. Type 2 still have problems like type 1s do. It takes longer for those problems to occur. So the type 2 diabetic that is a diabetic from age 30 to age 60 probably has a better underlying vasculature or nerves than the type 1 diabetic at age 30 that diagnosed at 20. Does that make sense? Sort of, kind of, maybe? Everybody just had a donut and can't even think right now?
Within reason.
Within reason. Very good. That was sarcasm, sir. Wow. Lots of treatments. So type 1 diabetics, what do they need? Insulin. Everything else is fluff. It doesn't work. We can do other things to help them keep their glucose down so they don't have long-term issues with it. But without insulin, they die. Type 2 diabetics is relatively a Western world, U.S., wealthy country issue because we have access to all this great food around here. So a lot of ways to treat it. We can give medicines that affect the GI tract. So you can absorb the glucose after you eat it. All right, you can inhibit absorption. We can give medicines called sulfonylureas that make the pancreas kind of give more insulin. We can decrease decrease the amount of glucagon that the body uses. A lot of things we can do. We'll talk about the sulfonylureas. Those are important. These are important. There's a drug out there. It's called Invocana. I forgot the generic name. But basically it says, yep, you're hyperglycemic. You had 12 donuts. Your glucose is 500. And we're going to give you a drug so that your kidney does not reabsorb glucose. And you just pee that out. And that lowers your glucose. But there are a lot of drugs out there. Metformin. If you've never seen a patient on metformin, again, you do not work in EMS, right? So a lot of issues with these medicines. But the goal is to decrease long-term hyperglycemia, right? So 3 things: sulfonylureas, metformin, and Invocana. Those are the drugs I recommend we ask about when we talk about our patients. If you've heard me talk about diabetes, I talk about if someone's a diabetic, I ask them, do you take shots or pills? Shots usually mean insulin. That means they're a higher risk for bad outcomes, be more aggressive. There are some new shots out there, but I'll still use the same thing, at least for the folks that we manage. So sulfonylureas basically squeeze the pancreas and make the pancreas secrete more insulin. So one of the theories of type 2 diabetics is that they've had an American lifestyle, they've had chronic hyperglycemia, so the pancreas is wearing out and tired, doesn't make a lot. So we give them a drug that makes them push out more insulin. Good thing, they don't need insulin for a while. They can be controlled by medications. The bad thing is at some point, the pancreas wears out, and that type 2 diabetic, if they're lucky and live long enough, they become a type 1. Change their type, right? Because now they have no insulin whatsoever, those medicines don't work. It wears out the pancreas, okay? So it does not affect resistance, anything like that. It just makes your body make more insulin. Metformin is kind of a lubricant. So you think about metformin doesn't affect insulin levels, and this is my redneck definition of pathology here, so don't get excited. But, whoa, that was weird. So insulin tries to get on these proteins to make the glucose come in. We talked about to make the things that the cell makes. So metformin makes this protein more receptive, makes it the insulin that you have work better. So if you have low level insulin, doesn't matter. Metformin makes it work, okay? Now, people don't like metformin. Metformin causes a lot of GI disturbances. So people who get started on metformin from the primary care side, the complaint we hear is, yeah, I took metformin for a few weeks and I was in the bathroom 4 times a day. I can't take it anymore. In reality, if you take it for about a month, you get used to it and it works pretty good. So metformin is a reasonably safe drug. Metformin can jack up your liver and cause lactic acidosis. So that's one of those weird things we think about in the ER that somebody comes in, they're acidotic, they don't look well, can't figure out the reason. Oh, you're on metformin. Now I know the reason. Again.
Question.
Yes, ma'am.
Metformin is the same thing as, I'm assuming metformin is, what is it, Januvia? I think Januvia,
I think that is a different drug. I think that is a drug that decreases gastric secretion, delays gastric movement, and also increases insulin levels in the pancreas. Now, I could be wrong. I'll have to Google that one. That's not a drug I write a lot. No? Okay. Thank you, sir. Good job. Yeah. The good thing about being an ER doc is I forget some of the primary care stuff.
I just know they took my mom off metformin and put her on Januvia.
Yeah.
Because she's like a borderline diabetic.
Yeah.
Because she was having the same issues with metformin.
The GI stuff?
The GI stuff.
Yeah,
and
right.
She took it for like, I say, 6 to 8 weeks.
Yeah,
Just to test it. And
right. So a lot of people, like I said, from a healthcare standpoint, if I got a patient that I want to get better and not have long-term hyperglycemia, and I give them metformin and they don't take it, there's no benefit for it, right? If they don't take it, whether they don't want to or it's the GI problem, it doesn't matter. They're not getting it. So sometimes we push people over to some of these injectables. So I think that's one of the injectables that.
No, it's a pill.
It's a pill? Okay. Well, then I don't have a clue then. I'll walk away. Thank you for smiling. All right. Hey, Chief, would you edit that part out, please, for me? Got it. All right. All right. Next slide. So Invocana is another drug, the third drug that I think about. I ask my patients. This is the one that affects the kidneys, and it makes them just pee out the glucose. All right. So the body's response in the kidneys to normal glucose is, hey, glucose is good. It feeds the brain. We need it. I'm going to keep it. But when your glucose is 400 every day, you don't need that, so you pee that out. And we'll talk about why these 3 drugs are important in a few minutes as far as managing patients in the pre-hospital setting. So in summary, think about sulfonylureas. They kind of squeeze the pancreas. You get increased insulin production. Metformin, really no big issues except some lactic acidosis, which is late in the game, but everybody takes it, it seems that way. And then Invocana, okay? These folks can get hypoglycemic pretty quick, especially if they're on a different drug, because the body doesn't reabsorb glucose. So they can get hypoglycemic, and they also get dehydrated, because instead of peeing 3 or 4 times a day like a normal human, you're peeing 3 or 4 times an hour, okay? And no comments from the old guys out there. Right, so first case, 50-year-old male, call for ultramental status. EMS says that his pulse rate is 120s. He's breathing 34. Blood pressure is soft at 95/60. He's setting fine at 96%. Entitled is 9. They actually have a great fire chief that bought them nasal capnography, which gives you a lot of data, right? D-stick read high. Okay. Exam, he's alert. Keeps saying Ethel or Edward or something with the E, and he looks pretty dry, right? So good medics get a 12 lead on the guy, because you think about diabetics can have heart disease, heart problems, and not feel it. And this is the 12 lead. I'm sorry I don't have a pink one. I couldn't get a pink copy. So that one, too fast, too slow, or okay?
Too fast.
Who knows? Yeah, so machine says it's 267. The pulse rate per EMS was 124. So you putting your hand on him, he's got a heart rate in the 120s, 130s, right? but the machine says that. So what's going on here? Yes, machine is wrong. Machine is seeing the T waves, right? So QRS complex, T wave. So machine is reading this, right? In reality, the machine should be reading this. So again, machines are cool. They're not always right. All right, so I'm going to start looking at injury patterns. Let's see if this works. Oh, this is so high tech. I wish Centerpoint had something like this. That's a joke.
I told you, you're welcome here anytime.
Okay. So 1, AVL, lateral. I got some T-wave inversions here, but no STEMI. 2, 3 in AVF, no STEMI. V1 through V4. It looks jacked up. I mean, it looks very abnormal, right? So it's really hard to diagnose or be diagnostic. AVR, is that up? Is that a T wave? I don't know. I go back and I look, and I'm not convinced there's a P wave anywhere. I say my QRS is kind of wide, and this dude looks bigger than my QRS complex, right? So what is going on with this patient? Yeah, I think I pushed this a lot. This happens frequently in the South. I had a resident this past weekend I was working with me. She wanted to show me a cool EKG, and it looked just like this. It was from like this weekend, okay? This is classic hyperkalemia gone wild. Normally, hyperkalemia is slow and wide, okay? Except when they have a reason to be dehydrated. This dude has a reason to be dehydrated, right? So this is hyperkalemia. I'm not going to interpret this for STEMI or no STEMI because he's hyperkalemic. I also know he's got what else going on, or why is he hyperkalemic? What's he got? Yeah, hyperglycemic. He's got DKA, right? So he's breathing 30 times a minute. So my first thought is, okay, he's got a respiratory problem. We need to manage that. And then I look and his SATs are fine. So now I'm like, why is he breathing fast, but he's not hypoxic, right? He's breathing off CO2. I throw this on, and it's like, wow, either my capnography isn't working or dude is pretty hypocapnic, right? He's breathing way too fast. Yeah, so he's a metabolic acidosis. So we talked about, could it be a lactic acidosis from metformin? It could be. Or it could just be plain old DKA, right? So is this guy sick or not sick? Sick. What if you just saw this part on the monitor? So this case was a couple of years ago, but what if you just looked up and he was on the 3 lead and you got this and you got this in altered mental status, but you don't do this and you don't do this, and you got this. Somebody's going to shock that. What happens when somebody shocks this?
Then he goes that way.
Yes, it goes back to what y'all said earlier, right? You get that other rhythm, right? So you shock hyperkalemia, and I'd bet you my $3 in my wallet that you get VFib. Then what happens is you give epi, start CPR, you intubate, you give amio, you shock again, and what happens? He never comes back. So dude just died because of what we did to him. Okay, now it's cool to run a cold, intubate, CPR, defibrillate, but you miss this and someone will die. So you got to use all the tools in your book. You can't think, okay, too fast, Y complex, tachycardia, heart rate 260, that's VTAC with a pulse, I'm going to synchronize cardiovert. If you do that, somebody dies. So you use all the tools. Now you start thinking, why in the crap is he breathing 30 times a minute? Okay, but not hypoxic. Why is he altered? Oh, glucose is high. What's his entitled? What can I do for this guy? So how do we manage this guy? What does he need? Yes. You said 6 beers? I think so. Wow. Man, where do you work? I'm going to come work there. You got 6 beers. That's good.
He retired from Centerpoint.
Okay. All right. Yeah. Oh my God. What have I started? So
Pre-chief ward days.
yeah. Okay. So dude is DKA, right? So the way we're going to treat this guy is he's going to get, somebody said IV fluids. He needs lots of fluids because he is super dehydrated, right? His glucose is high. He's probably been peeing that stuff off. He is way dehydrated. He's altered. He also needs calcium. Calcium treats or stabilizes the cardiac membrane. How much calcium does he get? Yeah, a gram. He gets the yellow box. Like adult medicine, he gets the yellow box, right? So is it category A or B? Yeah, I'm not sure why, but it is. So this is somebody that you're gonna, well, I can't say that, sir. So I recommend that someone calls, hey, I got a guy in DKA, hyperglycemic, he's got hyperkalemia on his 12 lead, he's pre-arrest, I'm gonna give calcium, start some fluids, I'll see you in a minute, okay? That's what I say you gotta say. But he needs calcium, and he needs IV fluids. And how much IV fluid does he need? A bunch. Wife says, he's got some heart failure. And you say, thanks for that information. Boop. He still gets a bunch of fluid, right? And if he gets gurgly, we sit him up and we manage that. He's got to get fluids. He's got to get calcium, right?
Is there a role for sodium bicarb in that case?
So I think there's a reasonable role for sodium bicarb. Entitled 9, he's metabolic acidosis, yes. Am I going to give calcium first or bicarb first?
Calcium.
I'm going to give calcium first. I'm going to start fluids. Somebody squeezing the bag in, and then you can do some bicarb. I think that's very reasonable.
Now, would you just do the bicarb push, or would you stick it in your bag?
Either way is reasonable. So for me, I don't do a lot of bicarb pushes because it's pretty concentrated, but you can do that. That's very reasonable. So this guy got fluids, calcium, and bicarb for me in the ER. So that's a very reasonable approach for him. So what's going on here is dude's a diabetic. He's actually a frequent at one of the places I work. He comes in 1 month hyperkalemic and in DKA, and the next month he comes in hypoglycemic. He had some mental challenges, and it's tough to manage his disease, so he was up and down. But basically what's going on is he was not enough insulin, so he got dehydrated, okay, and he got acidotic, right? When you think about DKA, always look for the reason. This guy's reason was non-compliance, not by his own fault, but just the way it was. Other reasons that can cause it would be a big freaking MI, a stroke, some kind of stress response. Maybe he's got COVID. That's the new thing I've heard about lately, right? Other issues, the car wreck, okay? The guy that breaks his femur in an MVC, they're prone to going to DKA in the next few hours, next few days as well, just because of stress. That's just 12 lead again without the rate on it. So IV fluids we talked about, calcium. If you're advanced practice, if you're a flight program and you got insulin, he needs insulin, 10 units or more, depending on what's going on. When you give insulin to somebody, insulin will make the potassium get lower. So a lot of times the people that are diabetics and DKA, if their EKG is normal, I don't give them insulin until I get numbers back. Because if their potassium is low, I got to give them potassium before I give insulin, or you can get hypokalemia and have a bad outcome. Sodium bicarb is reasonable, like we talked about, and fluids, 2 lines, fluids going in, okay? What about his respirations? He's breathing 30 times a minute. Do I want to try to slow his breathing down, bag him or anything? Let him breathe 30. He can breathe better on his own than I can. He's blowing off that CO2. Sit him up, let him work it out, let him breathe. If you're advanced practice, like a flight crew or something, this is the guy you do not want to slow him down and intubate him. If you do that, and he's breathing 30 times a minute, and his end tidal was 9, if I paralyze him, try to intubate him, and now I breathe 12 times a minute, what's going to happen? He's going to become more acidotic, and he's going to cardiac arrest. So if you do intubate this guy because he gets tired, or he's altered and vomiting, and you have to manage his airway, he's the guy that you give a couple of amps of bicarb push real quick, and then once he's intubated, you bag the mess out of him. This is the only patient that we hyperventilate in today's world is metabolic acidosis, and the most common is DKA.
Hey Doc, in that situation, this is going to be a type 1 diabetic that probably takes insulin at home.
Yes, sir.
Is it appropriate in that situation where he's so hyperkalemic there, call the hospital and say, hey, he's got insulin at home?
So I think that is a reasonable thought if you have a good relationship with your online med control and you know the type of insulin. So if he was on Lantus at home, Lantus is a long-acting. There's no indication for Lantus and DKA. It can kind of mess with you and be hard for us to manage in the hospital. But if it's regular insulin, or he has an insulin pump attached already, that's very reasonable to call and say, hey, can I do some of this? I would not recommend you give it IV just because if you're confused and you give the wrong type IV, it could be bad for them, okay? And also remember, if his blood pressure is 90 and he's in DKA, he's probably clamped down in those capillaries, right, or sub-Q. So if you give him sub-Q insulin, it may not work as well. But food for thought. If icy roads, can't get to a hospital, you're talking 2-hour transport with this guy, you know he's got insulin at home, heck yeah. Hey doc, here's the problem. We're 2 hours away, icy roads, diabetic, hyperkalemic, I'm treating that. He's got X insulin at home, he's got a pump on, can we give him some? A reasonable doctor will say, heck yeah, do that, okay?
Would that not also be the case if it's morose conditions and that bad that you call a bird in?
Yeah, if you can. Yes, sir. Yes, sir. Yeah, that guy, if that guy does not get advanced life support, he's going to die, right? And that's the goal of what we do is keep people alive, right? We can't fix everything. We can fix some things, right? I agree. Hyperosmolar, non-ketotic, or HUNK, is basically when you have a glucose that's greater than 500 or 600. Usually it's greater than 800. All right? Glucose is so high, they get confused. The cells get dehydrated. Their electrolytes get out of whack. They get confused. A lot of these folks are altered, and sometimes they even have stroke-like symptoms. So if I got a person that had an old stroke in the past or a mild stroke and never really knew it, and maybe had something that affects the brain on the right side, and now the glucose is 800, the blood pressure is low, they got poor fusion of the brain, they may have stroke-like symptoms. So hyperosmolar is concerning as well. The management for that is basically just like the management for DKA, except you don't usually see those folks having hyperglycemia or acidosis or metabolic acidosis. What you see is dehydration, confusion, altered mental status for those folks. Treatment is IV fluids, IV fluids, IV fluids. Once we get some labs, we start insulin. But this is the patient that I'm not going to give insulin to until I check a potassium level at the hospital. Okay. Now, if EKG shows hyperkalemia, I'm going to give them insulin without labs because the EKG told me it was there. Etiology of hyperosmolar can be anything. Tons and tons. I put all these little bitty words, I know Chief Ward likes the little bitty words. Anything. Stress, smoking too much weed, watching Alabama football, non-compliance, going to Sushi Village, lots of things can cause elevated glucose. Most common thing that I see is it's the person who was pre-diabetic 10 years ago when they saw their doctor, and now they're coming in ultra confused, weak, dizzy, blurry vision, check a glucose and it reads high. It's like, oh, guess what? You're no longer pre. Welcome to the club. So this is another reason we always get a glucose in our stroke patients to make sure. I don't want to give somebody a thrombolytic for a stroke when they need IV fluids. Then hyperglycemia. Hyperglycemia is just elevated blood glucose without any kind of other end organ acute issue. So if I went back there and had 2 donuts right now, my glucose would probably be 400. But I don't need IV fluids, hyperkalemia treatment, et cetera, et cetera. This is very common as well. So the way I kind of look at this on diabetic emergencies for high glucose is you look at the patient. So D-stick reads high, and the patient looks great. They're smoking a cigarette, asking for a sandwich, right? They're probably just hyperglycemic. Not much we're going to do. In the hospital, I'm going to do labs, things like that. For you guys, you can get IV access, give them some fluids, do an EKG, look for a reason their glucose is high, make sure we're not missing a STEMI, a crazy wound somewhere, something weird, and not much to do, okay? If the D-stick reads high and they're not breathing fast, not a metabolic acidosis, but they seem a little bit altered, a little concerning, okay? You think HUNK, hyperosmolar. Treatment's the same as this one, except I'm looking more closely for things that are bad, and the patient makes me more uncomfortable because they're not sick. I mean, because they are sicker than this person. Take that away. D-stick greater than 250-ish or high, and they have elevated heart rate, respiratory rate, you think DKA. Okay? Does that make sense? The glucose gives you a lot of freaking data. Some people complain that we can't get more labs in the pre-hospital world. I agree, we could use some more, but a D-stick gives you a lot of data. You got a D-stick, a SAT probe, and an EKG, you can diagnose a whole lot of stuff if you know what you're doing. Cool. Hypoglycemia. So people get concerned about hypoglycemia not being a big deal. Actually, what part of the body has to have glucose all the time? The brain, right? So hypoglycemia kills people. I can, right now I can think of 2 patients that I know died from hypoglycemia and not treatment, not aggressive enough treatment or delayed treatment based upon presentation to EMS. The point of that is, if someone has a low glucose, they're altered, we got to manage that. People can die from that, okay? So signs and symptoms early is diaphoresis, tremors, tachycardia, they feel weird, maybe some confusion. You can get some focal neurological deficits as well. Sometimes people seize, all right? And how do we treat hypoglycemia? So yeah, if they're awake, if they're able to eat, tolerate PO, give them some glucose. If you don't have the gel, you don't have the tabs, give them a pack of Skittles. Give them a donut, all right? If they can protect their airway and eat, let them eat. If they can't, you got 2 choices. You got glucagon or D50, or D10 now, because a lot of places don't have D50, right? So they need that. What if they are altered, diabetic, glucose reads low, snores respirations, breathing about 6 times a minute, last known well was a couple of hours ago, can you drill them and give them D50? Go like this. Yes. And if you don't, what happens to them? They die, right? So there's some concerns in the area about the state looking at every IO use and D50 use. So what? If they look at you, no big deal if you use it appropriately. If the patient's awake and alert, pisses you off and you drill them, you're in trouble, right? If they're altered, confused, about to die, hypoglycemic, you can't get IV access, you don't have glucagon, you drill them, you give them D50. They're not going to like you when they wake up, but it's better for them to wake up, call you names, report you to the state, things like that, than for them to die. And you're covered with that. If somebody gives you crap for that, reach out to me, okay? People die from hypoglycemia. Initially, there were some chronic or recurrent frequent flyers that some agencies were reportedly drilling so they would not call 911 to fix the hypoglycemia. If that's you, don't do that. That's wrong. But people will die if you don't fix this. So first case, 34-year-old female, history of diabetes, type 1. She's got an insulin pump, little bitty person, heart rate's 90, blood pressure, sats are good, glucose is low. She's nonverbal, can't get IV access. What do? You drill her. Yeah. Oh, I like that. Turn the pump off. So the numerous pumps out there, these are called pods. This one you can't turn off. This one you just take it and pull it off. They're not going to like you when they wake up. So be it. It doesn't hurt them. It's not attached to their pancreas. You're not going to pull out organs when you pull it out. It's just a sub-Q needle. Pull it out. There are other ones that look like this. You can unscrew this cap and pull it off. All right. If you don't know how to work this, that's fine. You can always take your scissors and cut that cable. It's not a cable. It's a plastic tubing. It's like an IV tubing. All right. These cost about $12,000 to $20,000. I will not break this, but this is easy to fix. Okay. So stop the pump, drill them, they get D50. Glucagon. Glucagon's a great drug. How does glucagon work? Squeezes. Yeah, it makes the liver squirt out extra stuff to make you get more glucose, right? Glucagon's great. It's an IM drug. You can give it IV for some things in the hospital. We can use it for beta blocker overdoses. The problem is when you give it IV, 2 things. One, as you push it, IV, they vomit. It's pretty cool. It's like magic. They vomit, they stop, they vomit, they stop. Okay? The other problem with it, if you're using it for like an overdose or something, is that it takes like 5 to 10 milligrams, and there's probably not 10 milligrams in the ER at UAB right now, so it's tough to get. The other problem with glucagon is if they're little bitty, 55 kilos, emaciated, it doesn't work. There are probably no stores of glucose in their liver. So alcoholics, skinny people, glucagon does not work. Typical Alabamians, glucagon works great. Sweet. All right.
And if I'm not mistaken, so if you have a patient, like the example you just gave us, she wouldn't be an effective candidate for glucagon.
Correct.
She's skinny.
Yeah, she's 55 kilos. She's a little bitty type 1. Glucagon's probably not going to work for her. Yes.
Okay, cool, but if she was a typical Alabamian
Yes, ma'am.
like me.
No, I didn't say that, ma'am. Clarify.
Then glucagon would be fine, I mean.
Glucagon is very reasonable.
Will we
Yeah.
use glucagon over drilling if they were?
So I think that's reasonable. So yeah. I would try the glucagon, give it 10 minutes or so.
That's $300.
Yeah. So, and it depends.
It's $300, but it's not a phone call about why did I get drilled and
Yeah.
woke up with this needle sticking out?
Right, yeah. So again, it goes back to your gestalt. So if you're looking at this patient and they're altered and you think, okay, they're a big person, glucagon's probably going to work. Yeah, let's try it. Pop them with the IM. Then you start looking for an IV again. You're still looking, right? You're still looking for your line, right? If you get there and the family says, yeah, we haven't talked to them since last night at midnight and now it's noon and they look like dirt, okay, they're critically ill, they make you uncomfortable, and your mind thinking, holy crap, that person drills and gets D50. Does that make sense? Your gestalt goes a long way with what's going on. Sweet. Somebody has mentioned in the past about giving D50 rectally. So I would recommend that you give no medicines via that route in the pre-hospital setting. Stay away from that orifice. If they need glucose, glucagon, drill them, D50, D10. I would avoid that. Yeah. So glucagon, yeah.
Take the needle off.
No. So yes, you can absorb medicines through the rectum, but there's no indication. So some kids that have seizure disorder still get rectal Valium sent home with them. If they have that and they want to give that, that's fine. I think if you show up on scene and the patient is hypoglycemic, you're not going to be giving rectal glucose. If you show up on scene and it's a kid with a seizure and mom has not given the rectal Valium, you have better drugs than that in your box, right? Now, if you're a BLS and you have no anti-seizure and you got a 5-year-old season for 20 minutes and mom has rectal Valium, yeah, say, hey mom, stick that there, give the medicine. You got a prescription for it, right? But I think us as a profession probably do not need to be doing that in the field. We have better ways to manage the patient. And I'm gonna move away from rectums. Bonus points. 84-year-old, belly pain, history of hypertension, but not a diabetic. Glucose is 400, breathing 32 times a minute, sat 98, end title's 9. Blood pressure is soft, heart rate is a little bit fast. EKG looks similar to the last one, prolonged PR. Remember, hyperkalemia is long PR interval, wide QRS, and peak T waves. So what's going on with this guy? Metabolic acidosis, right. So I'm going to start thinking about what caused him to get metabolic acidosis. He's 84, no history of diabetes, but he's 84, right? Probably has diabetes, okay? Remember that other things can cause elevated glucose, things like that. So he could be septic and have a high glucose because it's a stress response. So this guy on exam, he was obviously altered. We got IV access, giving him fluids, start doing an exam, touch his belly, and his belly is distended, and he screams when you touch it. Guy had diverticulitis, it perforated, and now he's got a big colon infection, peritonitis. So sick people that are altered, they get an exam. You get them naked, cut the clothes off. All right, look for things that kill people. Look for holes, wounds, patches, do a quick exam. Look for cool tattoos if you want to, I don't care. But get them undressed, expose them, roll them, look at them, and manage them. Otherwise, you miss things. Now, if you just gave that dude fluids, calcium, resuscitated him and got him to the hospital, okay, you still did a good job. You fixed his initial underlying thing that's going to kill him, which is the hyperkalemia and the acidosis. But if you didn't do the exam and find the fact that his belly was tender and he was septic, you're going to feel bad about it. Plus, you may go to the wrong hospital instead. Does that make sense? Cool. I'm not going to have a lot of time to talk about thyroid stuff. Again, Wikipedia is a great source. That's a joke. When you think about hypo and hyperthyroid, I think hyperthyroid is the big thing you don't want to miss. Somebody with a history of thyroid problems who is now altered, tachycardic, hypertensive. those folks can get sick pretty quick. We manage those in the hospital with beta blockers, IV fluids. But again, it's a diagnosis of exclusion. The way you determine if somebody is hyper or hypothyroid is how? Get a blood test, which you guys cannot get. So had a guy back in the fall that was altered, seeing things, maybe a history of psych disorder, tachycardic, diaphoretic, hypertensive. My gestalt was like, yeah, he's probably been smoking something, a little bit psychiatric patient. Then he also had a fever, like, now what's going on? Work him up, scanned him, bunch of labs, did a spinal tap, and then about 4 hours later, his thyroid come back, and his thyroid test was like super sky high. I'm like, oh, he's hyperthyroid. Now I can fix it. So you're not expected to diagnose this in the field, but you should understand the difference in hyper versus hypo and recognize that both can kill people. Hyperthyroid can kill you with stress, strokes, things like that, significant hypertension. Hypothyroid, I see more commonly in older people, the old folks from the nursing home who are now septic, altered, bradycardic, but septic. That doesn't make sense. They should be tachycardic, right? So things to think about with your thyroids. And again, the way we treat the thyroids in the hospital is we treat the symptoms, slow the heart rate down, we make it where they can't make more thyroid, and then we try to kill off the thyroid gland as well. Hypothyroidism is altered mental status. They're usually cold or hypothermic. They're bradycardic. They're altered. This, again, everybody in Alabama's got big legs, doesn't give me a lot of data. Things that I think about is the patient who is hypotensive and altered. I always start thinking, is there sepsis or something? If they're bradycardic, I think they're either on a beta blocker normally and the body can't respond, or maybe they're hypothyroid, right? So those are the clues to that. Another clue would be the person that is bradycardic, hypotensive, looks like dirt. You give them fluids too, they don't get better. You give push dose epi, they don't get better. Then you start thinking, okay, maybe hypothyroid or maybe some kind of endocrine Addison's disease issue there as well. Addison's disease or adrenal hypoplasia is basically the adrenal gland does not make chemicals. And what chemical does this make that we have to have? Yeah, so somebody said cortisone, steroids, but that goes down this long pathway, which I can't remember, but epi. So people with poor adrenals do not make epi, and they can have a lot of problems. So whether you treat this in the field or in the hospital, if you know they have this, they have some kind of stress event, they're not responsive to fluids or pressors, they get IV steroids. So those steroids can now go and turn into epi. And that's the key to that. Inappropriate humor, but out of time. Chief Ward mentioned this earlier. Remember, 112 lead does not give you all the information you need. Somebody shows up at a firehouse or your EMS or your agency, and they're like, hey, I don't feel good. Can you get an EKG? You get an EKG. You cannot now say he is not having a heart attack, right? I can look at this, look at my too fast, too slow, or okay, look at my injury patterns. I can say there is no STEMI, but he can still be having a heart attack because about 30 minutes later, this is this guy. And he just felt bad. He really felt bad then, right? So this one, too fast, too slow, or okay? Yeah, it's not okay, right? You can say anything else, but don't say okay. 3 things I think about that cause slow rhythms that you don't pick up in primary exam: heart attacks, electrolytes, or hyperkalemia. I would argue not hyperkalemia because I got different looking rhythms, right? I would argue that even though this is slow, that looks like a STEMI, that looks like a STEMI, it's probably a STEMI. You could also argue it's probably a complete heart block, but heart blocks for treatment management, me initially doesn't matter. So dude started not feeling well. This 12 lead pops up. I'm going to give him atropine. I'm starting fluids. I'm getting ready to get his airway because he's not going to last long probably. He's peri-arrest. He's getting high flow oxygen, 6 to 8 liters nasal cannula. Somebody's going to get my Lucas, bring in Nearest. All right. I push the atropine. I'm probably going to spike a dopamine, start hanging that. And somebody's opening up the crash cart. I'm getting ready for epis so that when it gets worse, I'm putting my pads on him to get ready to pace him. State says pacing for you guys is Cat B. Hopefully that will be changed in the summer, the next SMEC meeting. But if not, the way you control this is somebody's on the phone, and it could be your driver, your EMT, it could be the patient's spouse. I don't care who calls, right? And say, hey, got a 50-year-old male, bradycardic, peri-arrest, unresponsive to atropine, dopamine. I'm gonna give calcium and start pacing. And then you hang up, and they should say, okay. And that guy gets paced. Last thing, this is a patient that had had chest pain for 48 hours. He was picked up by an agency, and they were really close to the hospital they go to. You could actually see it from where they picked that guy up. And he's like been having chest pain for like, a couple of days. Very, I won't say well known, but known to the agency and the hospital. And the crew brings him into the hospital. They do a 3-lead, lead 2. No, it wasn't lead 2. It must have been lead 1. And look fine, and bring him into the hospital, and they're waiting on the wall for a few minutes, and they get this EKG. And what do you think of that EKG? He is not good, right? Yeah, so this is real bad. We're up in 2 and 3. Dude's having a STEMI. Weird thing was, he's well known to everybody. He always has chest pain. It's been going on for 2 days. So the first thought is, he is fine, right? They were a few minutes away from the hospital. No reason to do a 12 lead because we're fixing to be right there. And when we get to the hospital, they can do one. But what happens at the hospital? Do you get EKGs quick there in today's world? Nothing happens fast. So I would say there was probably no foul by not doing a 12 lead with a short transport. Okay, if you didn't have time, semi-reasonable. But I can tell you, you're going to feel bad when you get to the hospital and now you see this and you've been on the wall for a few minutes with this patient, right? Even though they're a chronic. And you miss this, you're going to go home and you're going to feel bad about it.
Is that an issue in AVR?
AVR, I think we got some kind of weird interventricular conduction delay. That's hard to say after all my coffee. So maybe, I think that it doesn't matter. I think that, crud bucket. I think this is enough to, and that. So I don't really care about AVR at this point in the game. Yeah. Yes. So I would say if you have a patient that you're concerned about ACS, that you do a 12 lead on scene before you start moving. Because in the back of a rescue or ambulance, it doesn't do well. Get that 12 lead, look at it, STEMI, no STEMI. If it's a STEMI, you go into a STEMI capable hospital. What if they showed up at a hospital that wasn't STEMI capable? So now I'm licensing this guy or he's going to the hospital, right? So early 12 lead, determine is it a STEMI or not STEMI. If it needs to be put in the system, put them in the system. If not, then move on. And you don't have to do the IV, all the other stuff if it's chronic pain, things like that. But this changes the direction of patient care. And if you miss it, you're going to feel bad, if nothing else. This is his cath. You can tell big difference pre and post, right? So even our frequent flyers get sick. Our ex-chairman at UAB, who I respected very much, would say that, what was the phrase? Even nuts fall from trees sometimes, right? So even our crazy psychotic patients, that's inappropriate, probably need to ick that out. But even our frequent flyers will eventually have some kind of health emergency we got to manage. So don't be that guy or gal that misses it. 1, it's bad for the patients, and 2, you're probably going to feel bad. And we don't have time for the videos. We'll show some of these in the skills labs. Questions, comments, statements within reason.
Got one from online, Doc. On hyperglycemic patients, we don't give insulin in the field. And so is that because it's better to be brought down at a slow rate, or why don't we give insulin in the field? I think is the crux of the question.
So that's a good question. I think in the setting of hyperkalemia, insulin in the field is very reasonable. I think it's something we've never really addressed. So it's something that could be done. The risk of giving insulin in the field to someone who is not hyperkalemic low is you can make them hypokalemic, and that can hurt them. So I think the only way you would give insulin in the field is if you had somebody with one of the EKGs that we showed today that you know is hyperkalemic. And that's going to be the occasional couple of times a year patient. So is it something that somebody wants to look into? I think that's something we can bring to the SMEC committee and talk about. But The cost of insulin is fairly high these days, and most of it has to be refrigerated too. So, but you would not give it without a lab test, except in the setting of hyperkalemia by EKG.
And role of thiamine.
So thiamine, we used to give thiamine to anybody that we thought was dehydrated, malnourished, or an alcoholic before we gave glucose for several reasons. I think that Dr. Vaughn talked about that a couple of weeks ago with the wasting syndrome. You can make things worse. We do not have many people in the U.S. that are malnourished and under starvation, ketosis, where thiamine is really warranted. So we don't give a lot of thiamine in the ER anymore. If I give it orally to somebody. If they cannot take things orally because they're intubated, then we give it IV. But I don't think you have to give thiamine before you give glucose, except in rare circumstances. So I would say not a big deal.
That's the question.
Yeah. So that needs to be taken to SMEC by somebody and ask them what they think. My opinion would be no, we don't need it. But there's more than my opinion out there, and I'm fairly wrong fairly often. Yeah, that's what it was. Yeah. So thank y'all for showing up. Great turnout day. Thank you, Chief Harvey. Appreciate you having us out here. Thanks to the Fire College today for sponsoring us. If I said anything inappropriate, I apologize. If I said something in medical care that you think is wrong or inappropriate, reach out to me. We can talk about it, because sometimes I do say things that are strange too. We're in Prattville next month, tentatively, and we're back at Center Point on the 2nd.